Hello, everyone, and welcome to Health or Consequences. We are the monthly Massachusetts Health Policy podcast sponsored by Commonwealth Beacon and Mass Inc. I'm your co-host, John McDonough from the Harvard Chan School of Public Health, and I'm joined by my colleague, Paul Hattis from the Lown Institute. Today, we are delighted to welcome back Dr. Eric Dickson, who is the president and CEO of UMass Memorial Healthcare, the major health system in central Massachusetts. He's got $3 billion plus in annual revenues, 2,400 physicians, 20,000 employees, 5 hospitals on 11 campuses. He's also professor of emergency medicine at the UMass Chan Medical School, and he's actually a graduate of UMass Medical School out there in Central Mass. And we want to talk to him about the waterfront of issues, particularly from the federal government with the One Big Beautiful Bill Act that the president signed on July 4th and what that means for providers, and also lots of other issues around consolidation in the healthcare system. So welcome, Eric. It's great to have you with us. Thanks for joining us again.
Great to see you, John, and good to see you as well, Paul.
Eric, let me add my words of welcome, and let's try to jump right into it. But before we even get into some of the meaty issues that John started to identify, we thought maybe a good place to start with you, given your tenure and your status as a long-serving CEO of a health system in our state, for you just to share some overarching impressions of where you think the Massachusetts healthcare ecosystem is right now. So, your thoughts?
Well, I appreciate the opportunity, and I love talking about healthcare and healthcare policy. And born and raised in Massachusetts, as you mentioned, I've graduated from 2 Chan schools, UMass Chan, as well as the Harvard School of Public Health. And at this point in my career, it's just really about trying to be a part of positive change here in Massachusetts. And so, it pains me, especially as an emergency physician, to look at the trajectory of some of the key metrics in healthcare in this state. As an emergency physician, I always look at emergency department waits and emergency department boarding, and Massachusetts now has the 3rd longest waits in the country for what we call door-to-doc time to see a provider in the emergency departments if you require acute care. And you say, why is that? And it has a lot to do with we have a real decline in primary care access in this state, which primary care is the foundation of any good healthcare system on a national, state level, or regional basis. So you don't have primary care, patients can't get seen early. They end up in the emergency department later in the course of the disease, which explains a lot about why healthcare costs so much in the state of Massachusetts. There's other reasons, but if you fail to take care of people early in the course of a disease, when you can basic prescription can keep you out of the hospital and out of the OR, and you don't do preventive measures because you can't get in to see your primary care doctor, you're going to get seen in the emergency department, which is the least efficient place to ever get care, unless it's a trauma or a heart attack or something that requires us. And that's going to drive up the cost of care. And so when I look at Massachusetts, healthcare costs too much in this state and really delivers too little to the people that it's meant to serve, especially if the color of their skin is non-white. And, I personally want to be a part of trying to write policy that can change that trajectory. But it's getting worse and worse every year. And given what's coming from Washington right now, it's going to become harder and harder to improve that situation.
So just to follow up on that, Eric, this is John. As long as I've been in Massachusetts health policy for about 40 years now, we've always looked at UMass Medical School as the place to grow and develop the best primary care physicians in the state. Is that still true? Has that changed? Have other schools declined in terms of producing primary care. What's the story behind that important statement that you just made?
UMass Chan is still a tremendous place to get educated for a primary care physician. We rank in the top 10th percentile for primary care education. Only medical school in the state. I think one of only two medical schools in New England that rank in that top 10th percentile. So it's still a great place to get a primary care education. The challenge for our students is they're paying a lot more to go to medical school than I ever paid. We had something called a learning contract that if you practice primary care or practiced in a high need area after graduation, they would waive 2/3 of your tuition over the 4 years. It was incredible. And that got a lot of people to go into primary care and see primary care as a viable option. And now with out of state students coming to UMass Chan, we're seeing the cost of education for them being very high, not as much as the other private schools, but still the out-of-state tuition is in the $70,000 a year range. So a lot of the students are doing the math, and they're really, really smart people, and saying, I'm not going to be able to afford to practice primary care and pay back my loans. And so we are starting to see our students, a smaller and smaller number of them, go into primary care, which is really scary when you look at the aging of the population, because you're going to need more primary care physicians, not less. This will become a nation of people with chronic disease. And as the population ages and medications get better to keep people alive longer. And so, it's a little bit scary to think about the shortage of primary care that exists today and how bad that will be 10 years from now if something doesn't change.
So Eric, thanks for clarifying that. That's really important. Um, we could talk the whole session together about primary care and physician training and so forth, but we want to touch on a lot of other topics too. So let's switch to the One Big Beautiful Bill Act that was signed by President Trump on July 4th that will have major financial impacts on the state, on medical care providers, including yours, with big hits on Medicaid, ACA, Affordable Care Act coverage, and all other kinds of streams of coverage. What are your greatest concerns for UMass and for the state from what you understand is coming at us now because of that new legislation that's signed into law?
Well, the impact on the healthcare systems across the state will differ greatly based on the percentage of Medicaid patients that you have, right? If you have a very small Medicaid base, you're not really going to be impacted much by this. There are a few hospitals that are in the single digits in terms of Medicaid percentage. We're at about 27% when we add our behavioral health company in, which is higher, which is in that safety net category, 67% governmental payer overall. So we will be impacted, and we will be impacted greatly. How bad will it be? It's hard to really know, because the work requirement, which will go into effect first on October 1st, 2026, will undoubtedly take people off Medicaid. We just don't know how many. And that's probably one of the biggest impacts for us. What the waiver will look like in 27 and beyond, will we get another waiver? Uh, will there be site-specific payments? We're kind of a pseudo-governmental healthcare system, having been created by an act of the legislature. We get a special Medicaid payment because of that. Will that be allowed? So our best guess is about 100 million. It could be as bad as 200 million. That we'll have to somehow take out of the budget on an expense basis or generate more revenue. And so we'll be greatly impacted by this. How badly will they kick the can down the road? We don't know. And so for us, I like to say, if you live in the past, you're depressed. If you live in the future, you're anxious. Try to live in today and be happy. We're just focused on doing everything we can to stay true to who we are, to shore up the organization as best we can today, where we have an operating loss, such that we'll be more prepared for whatever happens really for us in fiscal 27. So fiscal 26 is for us, that starts October 1st, is get your act in shape, run as efficiently as possible, because undoubtedly some bad things are going to happen in 27.
And are you already feeling the impact of cuts from the National Institutes for Health and CDC and other federal agencies that have supported the system for years?
Interestingly, when they created UMass Memorial and then separated UMass Medical School as the public medical school and us becoming a private entity, uh, all of the NIH work and research stayed with the school, and education, and all of the clinical work was thus. So they don't do clinical care. We don't do. So I don't have zero NIH funding at UMass Memorial, and you'd say, "Oh, so you're not impacted." Well, my physicians that work for us are heavily impacted by. Really, right now, it's not a cut in funding, but a slowdown in funding that may become a permanent cut down the line. So a lot of my providers that do both research and clinical care are, want the clinical system to make up for the loss in the flow of NIH funding, and that's how we're getting impacted. And we've had to say we're not going to be able to do that. So anything that hurts the school hurts UMass Memorial, and anything that hurts UMass Memorial hurts UMass Chan. We have a linked destiny, and but direct slowdown of cash to UMass Memorial, that hasn't happened.
Eric, turning back to your specific system, and you mentioned October 1 starting a new fiscal year where you're trying to get your act together. And that act has grown in recent years, both at your campus, has added beds. You just completed an affiliation or acquisition of Marlborough. Milford came in a more significant way before that. You have other hospitals in the system longer standing. You've talked about trying to help out when Neshoba Valley closed under Stewart, of perhaps doing something in the emergency department realm in your geography. When you put it all together, how are you guys doing right now as you head into, as you say, more challenging times ahead?
This has been a very tough fiscal year for us. We lost about $100 million in the first half of the year. Some of that was expected. We were bringing a new pavilion on board. First day of the fiscal year, Milford came on. They were losing money and had lost money for 5 years coming into the healthcare system. We opened up a big mail order pharmacy, and then our behavioral health company has really struggled, Community Health Link. So it's been a really tough year. Things are definitely getting better, and we haven't had any big layoffs or anything like that. We've tried to just really ask our frontline workforce for their ideas about how we can improve, and it's been fascinating. We have a very robust idea system within our frontline workforce, 200,000 ideas implemented in the last 10 years plus that I've been CEO. And especially when we ask for environmentally ideas, things that could help save the planet and help save UMass Memorial, they've been just amazing. So we've implemented hundreds of frontline staff ideas about how we can improve revenue, cut expenses, and it's really made a big difference here in the third quarter, and we'll post those numbers soon. But it's been a very challenging year. A lot of it has to do with anytime you open something, you have a lot of expense before it opens, and you don't have any revenue coming in to support it. Um, Milford is doing better. A lot of costs. What we didn't acquire Marlborough. Marlborough was already part of the system. We merged it into the medical center, but there's a lot of expense to go through the DON process to get that done. So it's been a tough year, but yet we've, for us, like we're going to add jobs this year, not cut jobs, and because like we need better access for our patients in the region, because so many things have deteriorated around us. So
Well, let's detail that a little bit more, because there has been speculation, or even your own discussion about doing something since the Neshoba Valley closed. Anything you can share with us and our listening audience about that today?
I can, and it's kind of the same story all the time. I've been a part of UMass Memorial for 35 years, really UMass before that, and then UMass Memorial when it was created. I started as a state employee here, and uh, Clinton goes bankrupt, so you bring Clinton Hospital in. Marlboro is struggling, so you bring Marlboro in. Southbridge and Harrington and lost money for 5 years in a row, and then Milford most recently, and you bring it into the system. So when something bad happens in central Massachusetts, we usually get called upon by the governor and the secretary to try to help. And most recently, it's been the closure of Neshoba, and really a very scary increase in the transport time for EMS in that Neshoba region. And as an emergency physician, I can say when people with time-sensitive illness wait longer for an ambulance and have longer transport times, bad things happen. And so we were asked to take a look at the state, see if there was something we were able to do. And we just bought a parcel of land we're about to close on in Groton, where we will put up a standalone emergency facility that will support the EMS in the region, and hopefully take a little bit of the pressure of the other ERs, Emerson and Leominster, and Lowell gets some of that volume as well, because they're all kind of overwhelmed right now in terms of the volume, and be able to stabilize, initiate treatment for the patients in that region, and then when necessary, get them transported. They wanted us to open the hospital, but we just couldn't do it.
If all goes as planned, any vision as to when that facility would open?
So in emergency medicine, we think about winters because that's when it's really bad, right? So things are pretty good down there today at the trauma center. And so we won't have it ready for this winter, but for the following winter, we're hopeful that we can get it up and running and be ready for that, cold and flu season, which if we continue to see a drop in the vaccine rates in this state and around this country, I mean, we're going to be in big trouble. One of the things that's coming from Washington right now is this de-emphasis on vaccines, probably the most important thing we've ever done in medicine in trying to eradicate polio and other diseases. And what that could do to emergency departments if you start to see surges in diseases long forgotten. Could really be crushing. So, yeah, we're hoping to be ready for a couple winters from now, before not before the next winter, but the winter after that, and hopefully all of my worry about the reemergence of diseases that we hadn't seen in years will not be warranted.
So there's a lot of concern and attention, Eric, in recent years to the issue of medical care system consolidation and having fewer providers and less competition. And there are some health policy experts who actually point to major consolidation as one of the major factors that's actually driving up the growth of healthcare spending. You are, with a lot of hard work over many, many years, by far the dominant provider in Central Mass, and you really don't have a rival in that. And so, wondering if you can reflect on that concern in the old days when we had certificate of need and determination of need in Massachusetts. The purpose of it was to prevent duplication of services. Now it appears that there's a concern that the consolidation has gone too far. How does that look to you from where you sit as not just the dominant medical provider, but you are in many ways the dominant public health service provider across central Massachusetts? So how do you square that circle?
First, from like a policy perspective and looking at the consolidation that has occurred in the state and the impact that it has typically had and around the country. In general, consolidation to date has not been a good thing, right? We haven't seen costs go down because of consolidation. And if anything, you've just been able to leverage your size and push for higher rates. And I think that if I didn't acknowledge that, I'd be looking at the evidence that's out there and just ignoring it. I think that's part of the problem in healthcare right now in healthcare policy. There's information glaring at you in your face, and you're going to ignore it and choose to go in a different direction. So I will say to date, policy around the country and in the state has probably done nothing to improve care or reduce cost, or what we all want to happen. I So there's ways that the policy could have prevented some of that, right? What if we had had a rate floor for the little places that cost less, and maybe a rate cap for the big places? And that's, other states have at least the rate cap. So, nobody wants to do a rate floor, but it's the small, lowest paid places in the state that close. And the ones that get into financial trouble and then eventually either close or get consolidated in. And Milford, which just came into the system, has some of the lowest rates in the state. And what they would say, they've never been able to stand tall and negotiate against big giant payers, so they've had to take what they were given, and so that's part of the problem. So one of the ways to have prevented that in the past, I think it's a little bit too late now, is to have some sort of a rate floor so that you can maintain those small places, like your Clinton hospitals, your Marlboroughs, or now even bigger places like Milford that have had to come into the system. The other answer I now say, having just graduated from the Stanford Healthcare AI certificate program, is there's no way you can survive as a small independent place now, given the requirements of your IT system of the future. One of the great hopes for improving our efficiency and as we move forward and improving the care that we deliver to patients is by mining our data in our central data repositories and leveraging AI to be able to identify patients that need to be treated differently and get them treated differently. It's our data platform alone is going to cost $100 million at some point. How does a little place even start to play that game? Or how does a little place leverage the AI tools that I can leverage, and they can't, and then they're expected to compete with me. So I think where I think, and I'll get beaten up by some of my healthcare colleagues for this, but I love, first and foremost, a Massachusetts born and raised kid that was given an amazing education at the state's only public medical school, and I owe Massachusetts. I think we probably need to see consolidation as a good thing so we can fully leverage IT, but we have to reel it in terms of rates by probably setting a floor and a cap. At some point, I think the health policy is going to come around to that, because mathematically, how else are you going to reel in the cost of healthcare?
So Eric, you've talked about the worries of those who are paid at the bottom, but when you were last with us a few years ago, a lot of the focus of our conversation was, well, somebody at the top of payment, Mass General Brigham, was at that point planning ambulatory care expansion, something that the state ultimately stopped. MGB is now back and on the table today as a primary care partnership with CVS. And they're also talking with Region Surgical about a new ambulatory care partnership. What do you make of all of this?
I would say, in general, expansion of the highest cost healthcare system in the state isn't good. The argument that, and this is an appropriate argument for MGB, is we're trying to do it in the ambulatory environment where it's lower cost. It's lower cost than the inpatient, but it's not lower cost than my ambulatory environment or us being able to do it. And so I think the Health Policy Commission and people are going to have to take a close look at any expansion of a high cost system, and they're not the only ones, and say, is this beneficial to the state of the Massachusetts? And my argument in Westboro was, if you take away Westboro, my best paying market that's still part of central Massachusetts, and leave me with the worst part of the market in terms of payer mix, not the patients. I love all the patients equally. I can't maintain critical services for the people of central Massachusetts. So I think you have to take that lens and look at it and say, what's best for the state overall. People have looked at us and say, is that a monopoly? Well, the, the test for a monopoly is what you're doing good or bad from a community benefit standard. And so if we could have 100% market share in central Massachusetts, and if it's good for central Massachusetts and the state of Massachusetts, that's not a monopoly. It's a monopoly is not defined by market share. Now, there are some market share thresholds where you should start to worry about it. And so I think you have to take that same community benefit lens and apply it to any expansion of a high cost system. And this is an expansion of a high cost system. Thank God we have MGB, because I send them patients all the time that we can't handle. It's 0.5% of one of our patients, and I'm so glad they're there when I need them. And we should try to not expand them into markets where you're dependent on another healthcare system that can deliver the care at a lower cost.
So, Eric, recently Blue Cross CEO Sarah Iselin went public in Commonwealth Beacon with an opinion column talking about the crisis of affordability in healthcare in Massachusetts, with double-digit premiums coming in the coming year and years on hikes on businesses and consumers. What do you think the state should do to address this? Would you support or agree with some kind of Maryland or Rhode Island style healthcare cost regulation, price regulation, or what do you think? I know you talk about the floors and the ceilings. Anything beyond that?
I think beyond that, we have to look at what's different about the U.S. healthcare system, the Massachusetts healthcare system, than the rest of the world. That seems to be, or at least the rest of the industrialized nations, wealthy nations that are that have their problems, but they're getting better healthcare at a lower cost. And I would say it comes down to two big things that we can address at a state level. We need better primary care in this state, and that's probably going to be spending a tiny bit more on primary care because it's such a small percentage of the spend overall, and such that we start building primary care practices and can recruit primary care and recruit people to not leave primary care and become hospitalists and specialists all the time. And the second thing is, like, our administrative cost in this state and this country is absolutely ridiculous. To be spending about 25% of the premium dollar on administration, the rest of the world runs for 6%, 7%. And there's a fantastic paper that came out of Harvard School of Public Health and that looked at the America versus the rest of the world and where are you really spending money. And it's in primary care sensitive diseases that end up in the hospital. And overutilization, that's about that and some imaging, it's the only overutilization you can find, and just administration. And so what I would say was, like, we have no room for this kind of administrative waste in the healthcare system, especially what's coming. And so caps on the administrative cost ratios, like we've done with dental insurance, wasn't low enough from my perspective. And really working to reduce not only the administrative expense on the insurance side, but my administrative expense. I don't have primary care doctors to see patients because they're filling out pre-authorizations for care that they know their patient needs, which is delaying their patient's care and adding huge costs on the insurance side and our side. So I think the two other things, beyond a price floor and cap, which again is not a popular thing, I have hospitals that would probably be capped, and I have hospitals that would be benefit from the floor potentially. I think we have to do primary care reform, and we have to do administrative cost reform, because we cannot afford to waste 25% of the premium dollar on administrative work.
Thanks for that, Eric. And finally, question that we have, you mentioned already the Health Policy Commission and its important role in the review of market transactions, but they now have been given the role by the legislature to develop a state healthcare plan. Are you hopeful, or are you concerned with what appears to be a rebirth of Massachusetts health system planning led by our state's Health Policy Commission?
Well, my answer is yes. I'm excited about this sense that we could finally take a look at a region and say, what services do we need there? And say, we're going to put a trauma center here, we need a pediatric inpatient here, but we don't need it here. We need a stroke center here, and we don't. That's what we should be doing. That's what other countries do, and it saves them a lot of money so that we're not all just competing for whatever the highest margin services are. This reasonable rationalization of what you put where could save a lot for the state. Well, at the same time, if people with limited knowledge of healthcare and how it works and the implications of the decisions they make come out with a plan, it could be a bad plan. And I've seen this. I've seen this in the state. I saw a decision made by the Secretary of Health and Human Services about rates for pediatric patients, that the only one hospital in the state was not going to have to bring their managed care rates down to the Medicaid rates because they want to do the Medicaid ACOs. And then I saw pediatric services across the state close, except for at Boston Children's, the only standalone pediatric hospital that didn't have to bring their rates down. And so now they gained market share with the closing of Floating Hospital, which was negatively impacted by that. And then your higher cost provider gained market share. And it's not Tufts' fault. It's not Boston Children's fault. But in the end, a good person with good intent made a decision, and it had a negative impact. That's what could come from this regional planning, and that's what I worry about. And for us, there's only 3 hospitals in central Massachusetts that aren't a part of UMass Memorial. 2 of them just came out of bankruptcy, in Gardner and Athol, and one of them is owned by Tenant, St. Vincent's, and has a lot of unstaffed beds right now. So kind of the regional plan for central Massachusetts is probably UMass Memorial doing everything. But it could have negative impacts, and that's what I worry the most about.
Eric Dickson, we appreciate so much you're joining us today. I think our audience is really can have a lot to think about after hearing your thoughts on a number of different issues. So thank you very much for joining us.
Well, thanks so much, John and Paul. I really appreciate the opportunity. And I'll end where I always end, is saying God bless all the healthcare workers out there, because in the end, no matter what happens in Washington or at the state level, they still come in every day. They staff our emergency departments, they staff our ORs, and they take care of patients doing the very best they can under trying circumstances. So God bless the healthcare workers out there.
Thanks again to Dr. Eric Dickson for joining us on the Codcast today. And thank you for listening. I'm Paul Hattis with John, and our producer today has been Charlie Cazella. Please do leave a rating and review wherever you're hearing this now if you want to help other folks find us. And email codcast@commonwealthbeacon.org if you ever want to get in touch directly.